Globally, oral cancer is the sixth most common type of cancer, with nearly 500,000 new cases reported annually. Most people are familiar with malignant melanoma and ovarian cancer, but oral cancer is just as prevalent as these diseases in North America. While oral cancer claims 50,000 lives per year in North America, most clinicians still have limited knowledge of the disease. Good evening, everyone. I'm James Cran, and welcome to this edition of Care to Know Pro Peer Perspective. We are extremely pleased to be joined by two leading experts who are going to talk and discuss about detecting and treating oral cancer. For those that have joined us previously, thank you. If this is a first time joining us for a peer perspective event, welcome. For those that can want to submit questions, there is the opportunity over the course of the next 45 minutes to an hour. As you can see on our platform, please submit questions. I'll make sure that Dr. Rennick and Dr. Young get to as many as we possibly can. But we do want to get started just because we have a very full hour ahead of us, based on some of the questions that were submitted prior to this evening. So why don't we start? I'll welcome Dr. Rennick and Dr. Young. And once again, on behalf of our audience this evening, thank you so much for taking time out of your busy days to join us. Why don't I start with Dr. Rennick? Maybe you can just kick off with telling our audience a little bit about yourself and your practice.
Sure. And thanks, James, for having me along. Always look forward to speaking to people about oral cancer. I practice oral surgery north of Toronto in the town of Newmarket. It was a town when I first came here, but we probably service about 400,000 people now. And I came here initially practicing general oral surgery, but I actually had a background as a pathologist. And so gradually over a period of time, my practice leaned in that direction. And so now the bulk of the patients that I see are patients with either precancerous lesions or cancerous lesions. And, my goal right now is to try to minimize the number of patients that are affected by this devastating disease.
Once again, Dr. Rennick, thank you for joining us. I know we're going to shift to stateside. Dr. Young, maybe you can take a moment and just, you were talking about Texas a minute ago. It makes me think of barbecue. I don't know if that's good or bad, but maybe you can take a moment to introduce yourself as well.
Not too good for my cholesterol, but thank you so much for the introduction. So I'm Simon Young. I'm actually Canadian. So I was born in Toronto. I went to dental school at the University of Toronto. But then I came down to the US, down here to the Texas Medical Center, which is the largest medical center here in North America. The city here serves about 4 million people. So when I finished up residency, the residency was combined with a PhD. So I am actually quite research focused. About 75% of my job here at the university with me as an associate professor, as an oral surgeon scientist, if you want to call it that, is working with the residents a couple of days a week and doing some private practice. But the rest of the time we actually run a lab that's NIH funded, and our interests are in biomaterials approaches for both tissue engineering but also cancer immunotherapy. So I'm very happy to be here to speak about this subject, because oral cancer is definitely one of the research things that we're very sort of excited about learning new ways to treat and diagnose. So thank you for inviting me on here.
Well, thank you, Dr. Young. And why don't we stay with you? And as I mentioned, we had a lot of questions submitted prior to this evening, but obviously we're here talking about oral cancer this evening. Maybe you can just do a quick refresher and talk a little bit about the significance and the impact that oral cancer has.
Yeah, absolutely. Happy to do that. The sad thing is oral cancer is one of those things that could be caught early, and unfortunately it's not. This is not a cancer that's buried deep inside your body that no one can see, that no one can feel, right? And so it's one of those things that really, should be caught early, but it's not. And if it's not caught early, which is the majority of the time, some of those effects can be quite devastating for patients because of the treatments that are required to treat oral cancer, whether it requires surgery, plus or minus radiotherapy, plus or minus chemotherapy, depending on the staging. When you think about things worldwide, oral cancer is actually pretty common. And if you look at, the statistics, apparently it's actually similar in incidence to uterine cancer, and it's more common than melanoma and ovarian cancer. But clearly, folks who have been doing sort of community education in the melanoma fields or ovarian cancer fields. I mean, I feel like everyone knows about melanoma. It's a deadly disease, but maybe not everyone, in the public knows about oral cancer. So there's definitely an educational opportunity there. And if you look at the statistics, here in North America, the incidence is about a little over 50,000 people a year get oral cancer, which when you look at it as a time measure on average, that means every 45 minutes, someone's getting oral cancer in this country, which is like a pretty staggering statistic when you think about it. And so, the unfortunate thing here is that we live in one of the most medically advanced countries in the world. And so by that, I mean, Canada and the US. And yet, for us, we even see this on the research side, there haven't been major innovations in terms of the improvements in overall survival for this disease. So if you look at someone who had oral cancer in the 1960s and the 1970s, overall, for all comers, they were looking at survival rates somewhere in the 50 to 60% range. And we're in 2023 and the numbers aren't staggeringly better, right? So definitely there's a lot of work that needs to be done. And I guess the last thing I would mention is that it's extremely expensive to treat these things. So if you look at some of these studies, there was a study, I think by Joe Califano's group at UCSD, where they kind of looked at the average cost of these, head and neck cancer patients. And so in the first year alone, you're looking at over $200,000 for treatment costs from US dollars just for that first year of treatment for these oral cancer patients. So, large burden on healthcare systems as well. So clearly, I think we all need to be doing a better job, both on the education side, the sort of the diagnostic side, and the treatment side.
Wow. Well, it was interesting when you said that there's someone diagnosed every 45 minutes, and you said it a couple of times, pretty staggering statistics.
Actually, James.
Yes, Dr. Rennie.
It's actually somebody dies every 45 minutes. Yeah. Somebody dies every 45 minutes from oral cancer in North America.
Staggering.
Yeah. Crazy. But we don't hear about it.
Yep.
So Dr. Rennick, tell us, how are these high-risk oral cancer patients currently being identified?
Sure. The real problem with oral cancer is late diagnosis. So even in advanced Western cultures, 75% of the patients that we see in the office or see in the hospital are diagnosed with advanced disease. And that's why the survival rate on these patients is so bad. And if you were actually to take a look at survival rates for a number of cancers, breast cancer, prostate cancer, the survival rates, and we'll talk about oral cancer too. If you go back to the 70s, the survival rates of these 5-year survival rates of these cancers were about 20%. And then you come across now to 2020, and the survival rate of breast cancer, probably 85%, maybe 90% 5-year survival rate. You take a look at prostate cancer, it's almost 98%. And you take a look at oral cancer, and we're still 65%. Worldwide, it's 50%. And in India, it's 20%. And so these are really terrible statistics. And the only way we're going to really solve this disease is to identify these patients at an early stage. And so that means not just identifying the patients with early cancers, but identifying the patients that are at high risk of developing cancer. So if we can find the high-risk patient, then we should be able to either prevent the disease from even developing, or see these patients at an earlier stage. So these patients present with a white patch or red and white patch in their mouth, and so it's very easy to have a look at. If you take a look at the cancers we were talking about before, prostate cancer, breast cancer, the people that are involved with these diseases, they have a great education program, they've got a great funding program, they've got a great research program, they've got great lobbying, they've got mammography, they've got PSA. They can identify the high-risk patients, and then they've got well-designed studies to direct them with the best treatment options. But we haven't done that in oral cancer yet. And so the big problem is identifying this high-risk patient. And unfortunately, the system that we use currently to identify the high-risk patient isn't working. So the gold standard to identify the high-risk patient is a test or a grading system we call dysplasia. So if a white patient comes into my office with a white patch in their mouth and I remove it, it goes off to the lab. Patient's relieved when I tell them that it's not cancer. They know it's not normal. Otherwise, we wouldn't have done the biopsy. And typically, they'll get a diagnosis of dysplasia. So it's a tissue. They've had surgery, and the tissue is potentially precancerous. But is this really a high-risk patient? And so we've been using dysplasia grading to try to identify the high-risk patient, but it really hasn't worked very well. And it's almost a flip of a coin as to who's going to get cancer. So we've been looking for years for a biomarker, a precancerous molecule that we can objectively measure, and then follow patients along and try to come up with a prediction tool to identify who the high-risk patient truly is. And we've been able to do that with breast cancer. We've been able to do that with prostate cancer. And we're just, I think, now developed a tool, or have a tool at our access to try to manage our cancer patients. All these cancers in the mouth develop from a pre-existing lesion called OPMD, or oral potentially malignant disease. They start as a white patch. They're easy to see, but trying to determine who this high-risk patient is and who's going to eventually transform into cancer has really been an enigma for us for 50 years.
Well, Dr. Young, Dr. Rannick just talked a lot about OPMD and dysplasia. Let's talk about diagnosis. So in this, in the case of oral cancer, who is typically making that diagnosis, or I guess more importantly, who should be making the diagnosis?
Right. And I think even before that, patients, they sometimes I wish, people looked in their mouths more often and realized, that when they see something that's red and white, that's not normal. It's not just a pizza burn, because I'm sure Dr. Rennick has also had patients where, there was like some sort of weird looking ulcer in their mouth. They waited a couple of weeks. Someone told them it was a pizza burn. Don't worry, it'll get better. 2 months later, it's still a pizza burn. But it's getting bigger. Like, that's a problem, right? So, step one is they need to recognize there's a problem. Step two, they go to one of their healthcare providers. Now, whether they go to a family physician and a family physician is able to identify something abnormal in the oral cavity, or, hopefully they are getting, very good general dentistry checkups every 6 months. And the general dentist is doing that. Everything that is taught in dental school still applies, in the sense that the clinical sort of oral exam is still the very most important thing that all dentists need to be doing when they see their patients. But, I think as Dr. Rennick shared with me earlier, we were discussing this, and he says there was actually a meta-analysis that was done that had almost 2,000 patients. And they showed that, clinical exam in itself doesn't really help you with a diagnosis, right? So, that's just step one, recognizing there's something wrong, right? And, some of the patient might say, well, I bit myself. Okay, well, if you think you bit yourself, or you think you burned yourself, how long has it been for? Well, I don't know. Okay, well, come back in 2 weeks. Right. And then if it's still there 2 weeks, 3 weeks works, then that needs to be biopsied. Right. Unless you can have a clear sort of traumatic, sort of etiology to it, those things deserve biopsy. And then so, someone, who has been diagnosed with a lesion that needs biopsy, that's not a diagnosis, just it's a treatment recommendation. Right. Then they'll see someone like Dr. Rennick or myself, or if the general dentist is comfortable doing it, they could do it. And then, they will take a little piece of the tissue, if it's, a large one, called an incisional biopsy. And then sometimes people might try to take the entire thing if it's small, but in general, our cancer surgeons here at our center prefer people just take a little piece of it first. And then that is sent, in a little container in formalin, it's fixed, and it gets sent to an oral pathologist. And just like Dr. Rennick said, the oral pathologist is gonna, they're gonna put it in essentially a block of wax, just like they did, decades ago. They're gonna cut little slices off of it, and they're gonna stain it with, hematoxin, which is basically pink and purple staining. And they're gonna use a technology that has not changed in like 50 or 60 years, right? And so they will take a look at it. It's almost like learning how to recognize cars. If you know nothing about cars, every car looks the same. If you're a car fan and something goes by, it's a Toyota, it's a GMC, it's a Ford, it's a whatever, right? And so that is like human recognition that's been going on for 50 years for these pink and purple stained sections to see, what sort of dysplasia this is, right? And as Dr. Rennick sort of alluded to, the oral pathologist using these classification systems that have been around for a long time with the WHO, they say it's either mild, moderate, severe, or even carcinoma in situ, basically just kind of saying what depth of that tissue are they seeing these abnormal cells. But the problem after all this time is that is a visual manifestation of, what particular is a molecular disease, right? So there's all these sort of molecular changes happening, but we're still using like 50-year-old technology for it, right? And so, before we get into discussing, what's on the horizon with this new system, we've been stuck basically just like with morphology, right? And the problem with that, when you talk about treatment and management, is that because the oral pathologist, will tell the surgeon, yeah, this is mild, this is moderate, this is severe. One problem is that, from one pathologist to the next, they might not agree on that same thing. So you could blind them in a study, and the chances of different pathologists rendering the exact same diagnosis is not that high. And they've also done studies where you can take a pathologist, and let's say you gave them 100 of these slides, you show it to them, they write down what they think it is, and then you tell them to come back like 4 or 5 months later when they forgot about it, and they come and they redo that, there may be variation there too. So that system has sort of, variation between graders, but even within the same person, it's not a very consistent, non-objective way of looking at this problem, right? Mm-hmm. And so, but the next problem is that when Dr. Rennick and I get that read back from the pathologist, it's not exactly clear in terms of the guidelines what to do with certain situations. So, a lot of clinicians will say, well, a mild dysplasia, maybe I'll just leave it alone, we'll watch it. And if you look at the literature, there are some guidelines, published in the past, I guess, around 2016, 2017, a group in Sheffield and a group in Liverpool. And, they basically have tried to give guidelines to clinicians that, consider things, such as whether it's mild, moderate, or severe, and then other sort of clinical factors in terms of, whether a smoker or not, or whether a male or female, or all these kind of things. But that's not a guarantee, right? So just because you have a mild diagnosis of dysplasia doesn't mean you can just tell the patient, okay, you're good. I looked at it, it's not going to become cancer, and you're discharged from my practice, right? At the same time, a lot of people, when they get a diagnosis back of severe dysplasia, the surgeon will usually choose to remove that lesion, but that doesn't mean the lesion's not going to come back, right? Because there's possibly molecular changes going on in that tissue that just happen to manifest as a red and white spot, at that time, but it could be that the whole area or a localized area in the oral cavity is affected by this process, and what people sort of called field cancerization. So just from this brief sort of story, you can tell like the old way of doing things is very sort of problematic.
Mm-hmm. And it's interesting. I love it. Thank you to our audience. There's a lot of questions coming in. Dr. Rennick, I want you to sort of weigh in on some of these gaps, because it sounds like there is. But a couple of questions have come in. One of you mentioned diagnosing early. Dr. Rennick, can you define what that means in your practice?
Sure. I'm going to take that question in a second, but I just want to, I want to get back to what Simon was talking to there about dysplasia. So dysplasia is currently the gold standard to try to identify who is at risk. And it's also what we're using to identify who's going to go on to get cancer. And it's not working. You can show the same slide to a pathologist and he agrees with himself 70% of the time. And so that's not really good for, guiding treatment. Now, the key to treatment is going to be to try to identify these cancers at a microinvasive stage. So when the tissue, all of these cancers start on the surface, the epithelium, the very surface of the mouth, and then they start to invade inside. And so you want to try to identify these patients at the microinvasive stage. So once they get any deeper, then they're going to be spreading to the local lymphatic channels, or they may be going down nerve channels. And now we've got, now we've got regional disease. And then, it will spread even further than that, and we'll end up with metastatic disease. And so if you take a look at the cure rate of patients that are identified at this early microinvasive stage, where the depth of invasion is less than 3 millimeters, they've got a 90% cure rate. And, if that's a long way from the average of 50%, or, the US number of 68%. So we need to take those advanced cases and push them backwards a bit. And so it all comes down to identifying that high-risk patient.
I'm sorry, I'm just reading. There's comments coming in. I'll just read a couple that have been submitted. One was around the guidelines are so unclear. That's why the survival rate is only 50%. Another comment came in: if the gold standard is so unreliable, then how is it a gold standard? But maybe we'll shift gears. And I thought that was a pretty good comment. But Dr. Young, is there what's on the horizon? I know people are here tonight because they saw the invite, obviously talking about a new test called STRATICYTE. Can you talk a little bit about, this test, if it's commercially available?
Yeah. And I really like that comment about someone saying, if this is the gold standard, like, why are we using it? Right. I mean, that is a great question, given leaps in technology and things that we know, like, why haven't we done any better? Right.
People are using this same dysplasia grading in esophageal lesions. They're using it in cervical lesions, and they're using it in breast lesions. And dysplasia is really just it's just a visual picture. We need to be looking at the molecular level. Sorry, Simon.
And that's a great point, right? Because I just wanted to emphasize, cancer and precancer, right, is a set of mutations, right? So essentially what happens is, your DNA when you're born, hopefully it's like, in pristine shape, but as time goes on, mutations can accumulate. You drink, you smoke, you chew betel nut, you get exposed to the sun, you eat all sorts of, who knows what's in our food supply nowadays. But anyways, right, you gain mutations. And as these mutations start to pile up over your lifetime, they may start hitting key genes that allow a cell to proliferate more, or like not differentiate into a final cell, but stay more stem-like, so you start to lose your body starts to lose control over sort of like the proliferation of some of these cells. So it's essentially a molecular problem. And we haven't been using molecular techniques to identify these molecular problems. Like, you're behind the ball already. By the time you notice there's a morphological change, there's tons of mutations already in that tissue. So I think that kind of is a great way to kind of segue into the technology we're going to discuss a little bit. And so, I was engaged by Dr. Rennick and his team, I guess, a couple of years ago, because we have an interest in cancer research. But, this company has been, looking at this technology for quite a while. It's probably been like 15 years or so. But essentially, the idea is that if you look at a population level, and so the initial data, I believe, came out of India, where they had hundreds of patients. And what they did these sort of screenings, these molecular screenings, to take people with cancer and then say, okay, what sort of proteins are abnormally expressed, in people with oral cancer, and they looked at something like 800 targets, and, about, 6 or 7 targets came up as possibilities because they were just abnormally high versus, the other ones. And so once they had an idea in terms of what sort of molecular changes were happening in these cancer patients, then the conversation, started switching to, well, if cancer is a process where you start off with, small molecular changes in dysplasia, and then if you wait too long, more molecular changes happen where you become cancer, maybe we should look at, what changes are happening in sort of these pre-malignancies, right? And then so, my understanding is that they approached, the team at Mount Sinai Hospital, where they had a great sort of longitudinal data set. So of course, running studies forward in time is difficult because it takes time and money, and if you have a rare disease, it takes a while to accumulate those patients. But looking back in time, if you have good data, is very valuable. And so what the folks at Mount Sinai Hospital had done is that they had meticulously sort of kept track of like over 100, maybe it was 150 patients, and they watched them over time. And they said, okay, patient ABC, they walk into my clinic today and they have dysplasia. And they wouldn't just, diagnose and kick him out the door. They followed these people over time. And so they would monitor them constantly to see if they got cancer or if they didn't get cancer. So when, it came time to look to see how good this marker was, they said, the folks in Toronto said, hey, great. We have 150 patients who we followed over time. We know who got cancer and who didn't get cancer, right? And then so we can run this test on their slides to see if this marker is there, and we can correlate that, right? So if it's a good marker and it predicts cancer, we'll know the truth because we know the patient got cancer or didn't. It happened in the past, right? So they did that retrospective work, and they basically started realizing that this marker, this one molecular protein called S100A7, and it's not a novel marker. It's been seen in other cancers. I think it's been in lung cancer and prostate cancer and other sort of cancers. So it's not like out in left field, but they applied it to this dysplasia situation. And what they found, if you look at some of the 2017 paper by Wong is probably one where they show the statistics on it, but looking at a combination of this S100A7 biomarker, which is it's a protein that has, and when it's abnormally regulated, it causes sort of the things that you associate with cancer, too much proliferation, not much differentiating going on. And so it's a bad actor when you have too much of it, right? So what this test does, it looks for, essentially abnormal high amounts of this protein with the stain. And then this is a very, this is like a really fancy word, like this is a very trendy word, AI. So an AI algorithm will take a look at that slide and see where that stain is, quantified, and also sort of look at like the morphology of the cells at the same time. And so the combination of this biomarker and the imaging algorithm associated with it, had a pretty good sort of performance. And so what we mean by that, it has a very high sensitivity. It's like about 96%. I mean, it's pretty accurate. Now, for screening tests like this, you want something that's very sensitive. So that means that you want to catch all the possible diseases. You don't want to accidentally tell someone that they don't have disease, right? And so sensitivity, sensitive tests, sometimes at the expense of getting like a false positive, but you want to capture all the possible things because, what's worse, cutting out a little lesion when you didn't have cancer versus missing cancer or pre-cancer. You don't want to miss those things, right? So this test, when you look at other sort of prognosticating tests, like in the breast cancer space. So, when you talk to Dr. Tony Moreland, who has looked at sort of, what they do in the breast space and look at, what this test is doing in the oral cancer space, it's pretty comparable. It's pretty good. It has a high sensitivity and has a fairly decent negative predictive value, about 78%, meaning, and what negative predictive value means is that when the clinician does that test, and if it says it's negative, like if you're not high risk, you can be fairly confident that patient will not progress to cancer. So you want to have a high NPV and you might have a high sensitivity. So from a statistics standpoint, this test also like meets those metrics.
Dr. Rennick, I'll let you weigh in, but one question came in. Can you just share with us what the name of the company is that you are referring to? Because it probably is maybe newer for most, but Dr. Rennick?
So the test that Simon and I are sort of alluding to is called the STRATICYTE test. And the STRATICYTE test was developed by Proteocyte Diagnostics or Proteocyte AI in Toronto. And they're based in the Mars Center, which is attached to Toronto General Hospital. And so Simon was talking about this a little bit earlier. S100A7 is involved with a number of cell regulation pathways involved in cellular division, cellular invasion. And it was used as a sort of a prognostic marker for patients with cancer in India because they had a limited budget. They wanted to know who were the people that were going to best survive. And so that the idea of from India came to Canada, and we thought, okay, let's try to interrupt this even sooner. So the STRATICYTE test was developed by a group at Mount Sinai Hospital, as Simon said. And then we started using it as part of an observational study in 2014. And so if I have a patient in my office that has a OPMD lesion, and I tell them that this shouldn't be there. Anything that's non-pink should not be in your mouth. We remove it. It gets sent to the lab for conventional histopathology. They then take a couple of sections through the slide. If the diagnosis truly is OPMD, then discuss with the patient whether they want to progress further and get the STRATICYTE testing done. If we decide to proceed with that, the STRATICYTE testing is going to give you a 5-year cancer prediction for this patient with about a 95% confidence level. Now, so the original biopsy that's sitting in the lab in a paraffin block, we take a couple extra sections out of that. Those sections are then stained immunohistochemically for S100A7. And then the slides are digitally imaged. And then those digital images are sent to Proteocyte. And Proteocyte, they, as Simon said, take a look at the morphology of the cells. They count every single cell that's in there, the nuclear cytoplasmic ratio, and then they also quantify the S100A7. Those two components go into a STRATICYTE score. That STRATICYTE score is compared to the outcomes of 150 patients that have known 150 patients that have known outcomes, and then we have a risk score for them. And so the clinician then gets a report back within usually a couple of weeks. And if the report comes back and the STRATICYTE score is high, and this is a patient I want to see in the office frequently. If it's low, it's probably a patient that can go back to a general dentist or to their physician for continued assessment. But those high-risk patients I see in my office every 3 months at least for the first 18 months, because that's when the highest risk of transformation or recurrence is. And then I continue to see them every 3 months thereafter. So it's really revolutionized the way I've practiced. And now, yes, I'm starting to see these patients at a microinvasive stage or even earlier than that. And, that's through 9 years of use of this test in practice.
Yeah, and that kind of leads into the next question. There's been quite a few that came through just asking about what's been your clinical experience. And I guess, Dr. Young, where is it fitting potentially into practice?
Yeah, we're very excited to bring it down here. So, I mean, clearly, it was developed in Toronto. And so here at our site here in Houston and our medical center, as well as other partner sites at Loma Linda and also, at UAB, University of Alabama in Birmingham, we are all collecting data right now to be able to bring this to patients down here. So, talking to Dr. Rennick, and, Dr. Rennick's also an oral pathologist. So I was learning a lot from him about how these tests are kind of put through the system. And, it's interesting because I guess in terms of the regulation, if you want to call it that, this test is sort of one of these advanced multi-analytical tests that also have like this imaging algorithm. So it's not just a stain, it's also an imaging AI-based algorithm on top of that gives you sort of this risk score. And so it's like a very advanced laboratory test. And so what we're trying to do here is, partner up with our, institutions, other academic institutions to try to gather that data. And so what we've done so far is that, we've collected, patients retrospectively, they have too. And the idea is that once we sort of get this data together and push it out there, we can hopefully get approvals for doing this as soon as possible. My understanding is I could actually already order it now as a clinician. And one of my partners in the university practice, Dr. James Melville, I think he already did it on 4 or 5 patients. And he said it was really easy because essentially what happens is, he's one of our cancer guys. And so, when these lesions came in, he biopsied them as we all do. And then when it came back as dysplasia, he just talked to the patients. He explained, that the best he can do is, with this 40-year-old system of looking at H&E, but he goes, there's a test that is now available that looks at changes molecularly that you can't see by eye, really, right? But you have to stain, for S100A7 and have the computer take a look at it. And, 4 or 5 of these patients, went through the process. And he said it was really easy because he just filled out a form. He put their name down. He put his name down. The biopsy, the person who did the biopsy has the slides, and he faxed it to, essentially the people who take care of that workflow for STRATICYTE. And then essentially, I think he just got an email back, a couple of weeks later with all the risk scores for his patients. And so it was neat because, I think if you have a patient who walk through the door with a really severe looking, terribly ulcerative, deep lesion, that's one thing. In their brain, they're already thinking, oh, I probably got something bad, right? But I think it's very, very transformative when you have someone with like a little teeny looking white thing that doesn't look like much. But then when this test comes back as something that could be really risky. So he had a patient who had a condition called PVL, which is proliferative verrucous leukoplakia. And, these things have a very high transformation rate, but to the patient, it's like, this is rough looking like white thing on my gum. It doesn't look like a big deal. And so when the pathology came back and then he showed them the score was like, it was like it was like 89%, risk of this thing becoming cancer. And that it's nice. That's very gratifying because as a clinician, those PVLs are pretty bad and they have a really high rate of becoming cancer. So it was really nice to see that, to help the patient understand like, hey, this little rough white thing in your mouth, it is a big deal. It doesn't look like a big deal to you, but this test, this advanced test is telling us it is. And it kind of almost feeds into what our intuition was as a clinician. So that was actually very gratifying to see.
Yeah. Clinical exams really do not identify the high-risk patients, and dysplasia grading wasn't helping us either. This is the only thing that's really given us any direction.
It's the same question, Dr. Rennick. Obviously, you've had a lot of experience with STRATICYTE. Maybe you can talk about your experience and also any sort of patient reaction.
Yeah, sure. Yeah, I mean, we've done STRATICYTE testing on over 1,000 patients now. And, in the past, like I've been doing this for a long time. And in the past, like Simon, I've seen patients with very minor lesions that have gone to, evolve into cancer 6 months later. And they've, their initial biopsy was mild dysplasia. I've had patients that had 8 or 10 biopsies, once they were biopsied once or twice a year over, a period of 5 or 6 years. Severe dysplasia, moderate dysplasia, never really evolved into anything. So dysplasia grading in clinical, examination wasn't doing it for us. So, now, and I'd see patients in the office that, unfortunately, I felt really bad because I'd given them poor advice, the best advice that I could give them at the time. But now I've got I've got an objective marker that is guiding my, my care of these patients right now. So, and since I've been using that, and it's, it's been as an observational study. The product just became commercially available in the last 6 months or so. But it's really affected my study, my practice. I don't see patients coming here with serious cancers anymore.
And there's been a couple of questions about how clinicians can order the test, but let's just put that to the side for a minute. A few other questions that have come in. I'll just read it. Is there a downside to initiating the STRATICYTE test early? Why wait for biopsy when the gold standard is so unreliable?
Sure, you have to biopsy the tissue. We're looking at down the road that maybe we could be using cytology scrapings on these patients. But, for now, it's, they need to be biopsied. Anybody that has a lesion in their mouth that is not pink, for which there is no, possible explanation, need a biopsy because clinical examination doesn't work. And then once you've biopsied them, then if they're OPMD, then recommend the STRATICYTE test, but you have to have that tissue.
And also, just to follow up on what Dr. Rennick was saying, to answer further about that question, I think what your viewers also have to understand is just like on the science side, these tests don't just come out of thin air, right? They come out of trials, or at least like retrospective data. And so, all the data that we have so far is, based on people who were classified as having dysplasias, following them over time, and then seeing, like whether they form cancer or not, right? And so we don't have a study where we just randomly take red and white lesions like that don't have a tissue diagnosis and then just run the test. So, at least, as it is right now, like, you have to have the diagnosis of dysplasia, or something like PVL or one of these sort of like OPMDs, then you run the test, because that's what the science dictates. Now, of course, there's lots of like interesting scientific questions we'd like to do in the future, right? Because that's what other sort of platforms have done with other diseases, right? This is just the start, right? I mean, we are early on in this, and we're doing it, but all this data is retrospective. It would be great to do sort of prospective work, but of course that'll take 5 years, right? Yeah. So, I think this is constantly evolving, and I think as long as your viewers know, this is definitely a step up than everything we have so far. And I'm pretty excited about it continuing to get better and evolving.
Yeah, we are in a prospective study now. And we're going to have some of those results out in the near future. Simon was mentioning about dysplasia. Now, in the OPMD classification, there's 11 entities there. And you don't necessarily have to have dysplasia. OPMD are 11 entities. And then on top of that, they can have dysplasia. And so you can have a white patch, which is hyperkeratosis, without any dysplasia, and it can still go on to develop cancer. And so, as I said, if it's not pink, it should be cut out. There was a research by the name of Shatterdeddy in 2020, and they looked at actually almost 5,000 patients, and some of those patients went on to develop cancer and some didn't. And of the patients that went on to develop cancer, 28% had no dysplasia whatsoever. They had a white patch, no dysplasia. So, dysplasia grading certainly wasn't going to help us out, but they already had, and Dr. Young alluded to this earlier, they already had those molecular changes before they had the morphological changes of dysplasia. So 28% of these patients went on to develop cancer. And we would have identified those, with the STRATICYTE test.
Now, I think Dr. Young touched on this earlier. A couple of questions have come in very similar. So how does a clinician order the STRATICYTE test? And maybe we can cover both Canada and the US, given that we do have an audience tonight from across North America. So Dr. Rennick in Canada, maybe you can comment on how this is available.
Oh, sorry, you're muted.
Yeah, it doesn't really matter if you're in Canada or the States. If you have the diagnosis of an OPMD lesion, and I guess, if there's dysplasia on top of that, then you just go to the STRATICYTE website or ProteoCyte website, or you go to the Patient Care Solutions website. The TRF is there, the test requisition form is there. You fill out the form, and then that's it. You send that in, and then Patient Care Solutions will contact your patient and ask them for payment for the test. They pay with their Visa, and then we do everything else. We contact the original lab. We get the microscopic slides cut. We get them stained, and then the digital images come over the border to Toronto, to the ProteoCyte location. AI then takes over from there, and then we get the report out. That report then goes by secure email back to the ordering clinician.
And just to be clear, Dr. Rennick, so it is available for all clinicians as of now.
Yeah, it is.
And so, you just mentioned, go ahead.
We are, like right now, our wet lab is in London, Ontario, actually. The ProteoCyte or the STRATICYTE diagnostics are done in Toronto. We will have a wet lab in the States and likely in the Houston area, but it's still a few months away.
Now, obviously, cost is always something that always is raised. You mentioned Visa a second ago. So what exactly is the cost and how is it covered in the US and in Canada?
Sure. So currently, the cost of the test is $500 US. In Canada, $650. Now, if you take a look at some of the other, and this is sort of as an introductory level, an introductory marketing program. Like if you take a look at comparable tests, they're usually about $2,000 or so. The tests currently are not covered by Medicare or likely private insurance companies. So we're giving patients a little bit of a break, but eventually, I think there'll be more widespread adoption. If you take a look at another test very similar to ours, and some of the viewers might be familiar with this, the Afirma test, and that was developed by STRATICYTE. And so the Afirma test is used to diagnose or direct care on the indeterminate thyroid nodule. So there's some thyroid nodules that the pathologist can't determine what their behavior is going to be, and the patient wants to know, do I have cancer or not? And so STRATICYTE developed a test, a predictive test for these nodules, and that testing as well came out somewhere around $400 or $600 when they first came out. As the tests became more widespread adopted, and they got coverage from third parties and Medicare, then the price went up to $2,000 or $3,000. And I think now they've got added more genetic markers to their tests, and it's almost up at $4,000. So the test, our test right now is really a bit of a bargain. And if you take a look, I tell patients, look, it's going to cost you $10 a month over the course of the next 5 years. To have some peace of mind that you're being guided with the most advanced and reliable technology that's available.
I just had a question come in. Will the test be covered in private insurance under flexible options that some patients have?
Yeah, it has been. Yeah, it has been in the past. Yep.
Well, I'll go back to something I think you both mentioned about someone dying. I believe you said, Dr. Rennick, every 45 minutes from oral cancer. And it sounds like there's a gap. And as we close out tonight's session, or excitement level for STRATICYTE now coming into North America. Maybe I'll start with you, Dr. Young, just sort of final thoughts for our audience and what you would like us to take away tonight.
I just want to maybe just leave people with the impression that I'm pretty excited about this. It's really about time we had something. Other cancers have their advanced tests. There's, as your viewers have said, there's no reason why we didn't have this thing before, and I'm glad someone finally did it. I wasn't sure, just because the market was small and there's just like less people in North America with oral cancer. But clearly, like you said, if one person's dying every 45 minutes, there's an unmet need. And now we finally have a way to, if you listen to Dr. Tony Morland when we talked about it, this is like the sleep well at night test. And what I mean by that is that it goes both ways, right? Because your patients, when they, if they get sort of like a low risk score, they can sleep better at night knowing that, their clinician didn't necessarily use something that's been used for 50 years and it hasn't been improved on. But also importantly, it actually makes the clinician feel better too. Right? Because you would feel terrible if you told your patient, you're probably fine. And then they walk back in the door like 6 months later or a year later with cancer. Right. And so it cuts both ways. I think it's helping us feel that we are really applying sort of like the best, newest sort of innovations that we can on a molecular scale to an age-old problem. And, my excitement and hope is that it will continue to even get better, and we'll have more tests like this across the board for many diseases as we go forward.
Thank you, Dr. Young. Dr. Rennick, same question, takeaways for this evening?
Yeah, this is really the biggest advance that's come along in oral cancer management in 50 years. And there's nobody currently in that space that has a marker that's anywhere nearly ready for commercial application. And, if we're going to try to make some sort of inroads in the 5-year survival of these patients, then it really all comes to identifying that high-risk patient. And we've failed miserably at that so far.
Well, Dr. Rennick, Dr. Young, on behalf of our Care to Know listeners this evening, it's been a very informative session. I think this was a new test, a lot of new information shared. On behalf of our audience tonight, I want to thank you both for once again taking the time and really bringing your insights and expertise to this very important topic this evening.
Thank you. I'd welcome patients to visit the Proteocyte website if they want more information.
Thank you, everyone. Good night.
Good night.
Good night.